of all, Tamsin, thank you so much for taking the time to do this interview. I think just a brief presentation of you as well. You're a professor at Child and Adolescent Psychiatry at the University of Cambridge and one of the keynote speakers at the ESCAP 2023 conference in Copenhagen. And your research is mainly focused on intervention and services to optimize the mental health of children and young people. And I get that also you have this special interest in the interface between educational services and mental health services. This is also part of what you'll be talking about in your keynote lecture. I'm just curious as to why you think this is a field that should be of interest to child and adolescent psychiatrists.
Well, first of all, I'd like to thank you and your colleagues for inviting me to give a keynote, and I'm tremendously looking forward to coming to Copenhagen, which I've been to very briefly once, and to meeting colleagues from across Europe. I can remember as a very junior child psychiatrist, but I wasn't. So postgraduate medical education in the UK, you do 3 years after you've got your medical degree. You have 3 years basically core psychiatric training, and you have to do some general adult psychiatry and some old age psychiatry, and then you often get the chance to do child psychiatry or psychiatry of intellectual disability, etc. And then when you've got some more exams, you specialize if you're going into things like child psychiatry. So I was in my first job as a child psychiatrist, and actually talking to the then Professor Anthony Cox at Guy's Hospital, which is a big teaching hospital in London, who was describing, doing school visits and not being able to keep my mouth shut. I said, well, is that really worth the time of a psychiatrist to go and spend a whole morning in school? And he kind of looked at me as if I was, totally beyond the pale, and said, well, what's a morning in a child's life? And I thought, yeah, but are we really that important? And I have to say I wasn't convinced. Although I was trained that you had to at least speak to teachers as part of your assessment. Children spend a lot of time in school, and also teachers bring a different perspective because most of us come from small families these days. So we've grown up with few siblings, we have few siblings, so our range of children, if you don't work with children, your knowledge of what the normal range of children is really quite limited. And I guess by the time I'd qualified as a consultant psychiatrist, I kind of got that. It was my research work that just kept bringing me back to schools. So my first big piece of work was my PhD, which demonstrated that basically teachers were the most commonly consulted mental health professional, that they're essentially the first line mental health service, but they're not trained to do that. And then I got interested in children with difficult behaviour, and of course the nice National Institute of Clinical Care excellence guidelines in the UK are parent training, but I kept seeing families clinically, often with children with neurodevelopmental disorders, who were knocked backwards because there were problems at school, and no amount of training the parents is going to sort a problem at school. And this was around the time that the Incredible Years parenting package was just going all over the world. And although Carolyn Webster Stratton developed the 3-pronged package, actually in most of the UK, with the notable exception of Wales, it wasn't being implemented. And yet children with poor mental health were being excluded from school more often, their outcomes are appalling. And it just felt like this, taking that programme and testing it as a public health intervention might be a really neat way to support children to cope in schools and support teachers to deal with the children that they found most difficult. And the more I've worked at that interface, I do think the interesting, exciting academic things happen when you have people coming together with different perspective at those interfaces. It can be quite tricky. We often don't understand each other in the way that we think we do. But I think that's where really exciting, innovative work happens. And, you know, I think teachers are really well aware that mental health is a huge impediment to children coping at school. And schools are a really important setting for children, particularly if things aren't going very well at home. So you know, thinking back to that conversation in the mid-1990s with Tony Cox, I think he's right. You know, I think all child psychiatrists and all mental health practitioners need to be liaising with their colleagues in education, but it needs to be a dialogue. It needs to go both ways. And I think there is a lot of research that we could do about how schools can support children, but also how we as mental health practitioners can support schools and the staff within them to optimize the environment for children.
I agree with you, and I think you mentioned as well, so this multidisciplinary work that has to take place as well when you're working with whether it's schools or other services, because our children do come in touch with so many different services other than just mental health services. And some would argue that the most important, or that we're maybe not the best qualified to do research in this field, or to take part, that it's better that to just leave that up to teachers, or to leave that up to social workers or whoever it might be. What perspective do you think that we bring as child psychiatrists that's important in this dialogue and in this research field?
I think that everyone has something to offer. And I think all the perspectives are important. I think it's, you know, what is predominant or whether any one of them should be predominant will depend on the particular research question you're asking and the particular context that it's in. But I think any research or any clinical service or indeed education practice will be enriched by having a multidisciplinary presence. And, you know, we will have all experienced teams with dynamic problems, but actually there is nothing like working in a really good multidisciplinary team when it's working well, and all of human interaction generates friction. Being able to problem solve and, you know, manage that, and actually sometimes really good things come from those frictions and the heated debates. So I don't think there's sort of definite no-go areas. I do think that child and adolescent psychiatry or child psychology or developmental psychology, you know, we all have a slightly different spin and we all have something to contribute. I don't think there are any no-go areas, but I think equally I would temper that with we absolutely need to be respectful and to hear those other voices and those other lenses for seeing the world. And they all offer something, they just address different questions and they're suitable in different contexts.
I would tend to agree, or I do agree with you. And I think sometimes it's when you have those conversations as well, is when you realize why you also develop a common language where you become more aware, you learn the other people's language, which makes it easier to sort of consult into different contexts if you spend time in those conversations as well.
Absolutely.
So you mentioned that the study you did about the incredible years as a public health intervention, but could you tell us a little bit about what you're currently involved in with studies, or what's taking up most of your time?
What's taking up most of my time at the moment? Well, there has been a national survey programme in the UK which started in 1999, and in fact my very, very first research job, I had my piece of paper saying I could be an NHS consultant child psychiatrist, and I went off to do a research job for 6 months and essentially never came back. Was on that very first survey. The last survey was in 2017, and of course when the pandemic hit, it made perfect sense to go back to that very carefully constructed probability sample of the population. And so we have been surveying them every year since 2020. although it's not sort of an equal play, you know, because it's government funding, we have to go back each time and get funding. So there is a wealth of sort of pure epidemiology work to do, which I'm really enjoying after a bit of a break. The other thing I am working on is the use of computer adaptive testing, which this is when you get an item bank of, well, the one we're working on, we hope to have sort of 250 different items from different questionnaires, and you get people to complete, not all of it would take forever, but we're going to get children to complete about 40 items each that overlap in a way that means that we get a really good spread of people. So we'll have about 4,000 children. We'll have a sort of good reference population. And then you can write an algorithm that basically will select the next item you ask a child who's filling in this questionnaire is related to how they've answered the one before. So instead of having to pile through a big load of questionnaires, actually the version for adults we used in the pandemic with our undergraduate students. So, okay, they're Cambridge undergraduates, they'll be fluent readers, but it was taking under 2.5 minutes for the algorithm to say, right, I know where you are on the spectrum of thriving to really distressed. Which then becomes possible for people to use to either screen in schools or to measure how different year groups are going or the impact of policy changes, because you are talking, you know, 5-10 minutes in a registration session and not, you know, perhaps 45 minutes or a whole lesson. So that's another really exciting piece of work that we're working up in schools. And then finally, we've just got a program grant to study mindfulness based cognitive therapy in children who are at risk of becoming the adults for whom it's currently recommended. So in the UK, MBCT is recommended for adults who have had 3 or more episodes of depression. But the problem is, once you've had 3 or more episodes of depression, often life is pretty tough and it's quite hard to get well. And one of the risk factors is to experience your first episode in your teenage years. You're much more likely to have recurrent depression. And children who are depressed pay a very heavy developmental price. You know, you don't, in those mid-teenage years, you really don't want to be not functioning for 6 months a year, because then you are so far socially and academically behind your peers, it becomes much harder to build your confidence again. So we will be recruiting from mental health services children who've either not responded to a first-line treatment for depression, or they did recover, but they've relapsed quickly. So we're trying to get, you know, we're not suggesting this is for everyone, because the adult literature suggests it's not for everyone, but it is as potent as medication in keeping adults well. And so we wonder if, you know, why wait till middle age? Why not try and teach people the skills earlier? So this is with colleagues at King's College London, Exeter and Surrey, and there's a whole programme of work with the trial that I will lead, but we're also honing our training programme because we don't have very many mindfulness teachers who also have experience of working with children and young people. There is a really interesting problem in measuring mindfulness too, which is that as people become more aware, self-aware of themselves, they rate themselves lower. So in fact, there is this kind of U shape. So, you know, you can have university undergraduates who rate themselves as more mindful than Buddhist priests, which I suspect is not likely. So we've got a work package about the measurement issues, but particularly also practice. So in the adult literature, it's the amount that you practice that predicates whether or not you get better. And those who do practice, actually, their improvement continues beyond the actual treatment. But it's quite difficult to get teenagers to essentially sit and do nothing. So we're trying to co-produce an app that will see if we can combine some kind of gaming but in a mindful way. So in other words, mindful purists would probably be, feeling like they've just heard nails scraping down a blackboard. But actually, isn't the important thing that we get the kids to do it? So we can find a way of making it more appealing and making it happen, because in all of our feasibility work, the real issue has been getting people to practice. And then the final thing is about implementation. So can we learn about facilitators and barriers in the CAM services we're working with, so that if the trial does suggest it's effective and cost effective, that we can implement it across the country. So really exciting time, and quite a lot to do.
Yeah, it sounds like you're quite busy. So we are very, very happy that you're taking the time to come to Copenhagen and give a keynote lecture. And we'll be looking very much forward to hearing and maybe hearing a little bit of update on what is keeping you busy these days. So thank you so much.